That last point you brought up is something you told me probably just a couple months ago, and that really changed the way I look at research and clinical trials. Because I'm someone, I don't really enjoy doing bench research. I've been through that. I've done that in the past, and yeah, it was very helpful. What I enjoy is clinical research, trying out technologies, really helping to contribute to our field of refractive surgery, refractive cataract surgery, and just sort of push the bar of patient outcomes forward. And you had mentioned that there's other parts of the world, right, where, like India, for example, where some of your friends, they have their private practice clinic where they perform surgery, but then they also almost have a second clinic that's more charitable, charity based.
Right.
And they're able, and the financial and economics of conducting surgery are very different in the US versus other parts of the world. And you sort of related that being involved in these clinical studies, being able to enroll these patients who maybe otherwise couldn't afford a multifocal lens or an extended depth of focus lens, you can almost still do that charitable surgery for them at no expense to them. And that's kind of, you viewed your way as doing that. And that to me is really powerful and not something I'd ever considered or looked at from that perspective before.
Yeah, no, definitely. I mean, I think I love the fact that we can advance the field, advance technology, things like that. But I think for me, there's definitely some patients that come that we may see that maybe they have 2.5 diopter of astigmatism. And your heart, you know that if I could put a toric lens in there, they're going to be seeing so much better than if they don't. And unfortunately, they may not have the means to pay for a toric lens. So then the situation is, well, do I just go ahead and put in a basic lens and then they just get the astigmatism afterwards? Or can I get them into a trial? And now they've got that opportunity of getting that toric lens. So that's where I see that there's a benefit for our patients as well, for those patients that can't afford that.
And the amazing thing about these IOL trials is most people, when they think about medical research, they think, oh, someone's going to be taking blood from me. They're going to be running these unknown tests. Who knows where that information is going to go? But for these trials, the surgery is the exact same as a surgery otherwise would be. Really, the only obligation on the patient's part is to show up for an extra few follow-up visits, just so we can essentially provide more care to them, do more eye exams, make sure everything is really, really the way we want it to be. And so it's really a low barrier to entry, I think, for the patients.
I think the other big advantage we have here, sitting here in the US, is a lot of the lenses that we're using are not lenses that are unfamiliar to us. We live in a global society, and many times we already know that there's certain lenses that are available in Europe that we don't have over here. So when a company comes to us and says, hey, we've got this particular lens that is not available in the US, like, for example, EVO and the ICL. I mean, we've been dying for EVO for the last 10, 15 years in the US. And so when the opportunity came to do that trial in the US, from my perspective, when I'm talking to a patient, I can look them in the face and tell them that this is a research trial, but the reality is that, as far as I'm concerned, this should be the lens you should be using right here. I mean, there's nothing experimental about this lens. This lens has been tried in hundreds of thousands of patients. They do extremely well with this lens. And the beauty about this for you in the US is you're getting the opportunity of getting this lens at no extra cost to you. So because we're always a little bit behind compared to the rest of the world, it's something that becomes much easier to convince patients that to be part. Because normally when you hear the word research or trial, the patient's, the first instinct is, well, I don't want to be a guinea pig. I mean, this is my first set of eyes, my only set of eyes. I don't want to take a chance, stuff like that. But when you can let them know that, well, this is really not truly experimental, but something that we have good experience with, becomes much easier from that perspective.
It's so unique, isn't it? I mean, to be able to, the same thing, EVO patients come in and say, oh, I want this experimental ICL. And I say, we have a decade worth of clinical evidence. The rest of the world has already done the clinical trials. We are just finally getting our hands on it now. It's the same way with SMILE.
Right.
Your patients say, well, SMILE is the new procedure, right? And I say, well, relatively new relative to LASIK. That's maybe been around 25, 30 years. We've been involved with SMILE from the very beginning, but SMILE's been around even longer than our experience with it, just in the rest of the world.
Correct.
And so we're able to offer these patients the latest cutting edge technology, the best sort of precision and refractive outcomes at no cost to them. And there's very little risk involved. I mean, almost no risk beyond just the normal risks of having any eye surgery done.